very good morning, everyone. Welcome to another episode of Breakfast at UMHealth show. I'm Selvee from Department of Molecular Medicine, Faculty of Medicine. Today, we are very privileged to have Dr. Balraj Sethi from Novartis, Malaysia. Dr. Sethi is the Country Medical Affairs Head at Novartis and has a vast experience in this domain. Today, we're going to hear him talk us through immunotherapy's next wave, transforming cancer care. Dr. Sethi, over to you.
Thank you. Thank you so much. Thank you for this invitation for me to share some of my experience and my enthusiasm on immunotherapy. I'm Dr. Balraj. I'm the head of medical affairs. Although recently in Novartis we have not really been working very closely to immunotherapy. However, we are always trying to find a different combination which we hope can actually increase the survival or disease-free recurrence when we combine certain treatment modalities with PD-L1 or similar immunotherapies. So let me just walk you through some of the things which I find will be very relevant in the next few years. Again, the field of immunotherapy in the past 10 years has really evolved so vastly that we are now having 2 3 days conferences around immunotherapy alone. So in these 20 minutes I'm going to focus on few key things which I think has really making a breakthrough. So let's us just start with the case first. So this is a case of one of my colleagues in Imperial College of London. Patient was 67-year-old female, was presented with Hep B positive, liver cirrhosis is 99 on antivirals with child puke class A, ECOG score of 1, presenting symptom was nausea and weight loss. After ultrasound, she was actually alpha fetoprotein was done, which was elevated, and then CT and MRI was done with biopsy, which actually confirms the suspicion of HCC. So, based on the recent finding of IM Brave 150, which was atezolizumab, a PDL1 plus with bevacizumab, anti-VEGF, 15 mg per kg every 3 weekly was started. Based on this study, we know that the median overall survival is 19.2 months, PFS is 6.9 months, and objective response rate is about 13. However, after 4 cycles, that is 12 weeks, when the scan was repeated, it actually showed progressive disease, new lungs mets, and also lymphangitis. So why is that? And this is really has been the challenge with immunotherapy. Although after 10 years, we have actually overcome some innate resistance by actually combinations. You just saw a combination with a VEGF monoclonal antibody, bevacizumab, but we still see quite a lot of innate and also acquired resistance. Our understanding over the years have evolved, although the first paper on the CTLA4 was actually published on in 1996. It has been 35 years really to learn our immune system and how cancer actually manipulates it to escape the system. However, in 2010 was really when we made a breakthrough, when we actually found that the program that ligand actually really exhausts the T cells by inhibiting it. Since then, in the last 10 years, there has been quite big focus on immunotherapy to really find different path which can actually enable us to really find the immune escape which the cancer cells really use. And you can see there are quite a lot of targets which we have been focusing, but at the same time we realize that the unresponsiveness to treatment is really much more deeper. And this was really nicely, put together by Dr. Semak in 2020 publication, which really explained about the unresponsiveness to IO, and what are the several factors which really, influence that. So he actually divides it into four and into two domain, which is extrinsic, that means outside the tumor, and then intrinsic, some things which is happening within the cell itself. So the cell infiltrates, these are really a concept where we understand now that Treg or even macrophages can be recruited by the cancer cells to actually protect the cancer cells. And this can actually ensure that the T cells are not infiltrating into the tumor and, really getting rid of the tumor. The second external factor which we understand is really the physical factor, where the tumor actually creates a hypoxic environment, and that leads to induced factors like the hypoxic induced factors, which then increase the vasculature of the tumor, thus having formed new vessels, which really helps the tumor then to get nutritions to grow faster. It also can actually induce cancer-associated fibroblasts, which for years now we know is one of the main reason for chemo resistance. And thirdly, this is more of an internal factor. We know that interferon gamma expression can actually increase MHC class 1 expressions, and it can actually help to detect tumor. However, this pathway sometimes can be manipulated by tumors either to overly express PDL1. That means the more PDL1 is expressed on the tumor, it can actually inhibit the T cells, or at the same time, it can actually lower the MHC class 1 expression. Thus, the tumor cannot be identified. So there's a lot of research being done around this corner. And lastly, this domain is really around the signature or gene signature expression, where the tumor can actually manipulate various genes within the cell itself to actually escape the immune system. Now, around these four domains, there are really almost 50 different concepts on what we can do to really increase the responsiveness of IO. But what I'm going to focus today is just the top two, cell infiltrate and interferon signaling. Actually, interferon signaling has been one of the main domain where we have been targeting in the past, several years. And it really started from combining IO with chemotherapy, with radiotherapy, as it can induce DAMs and PAMs, which can then help the dendritic cells to detect these antigens and then bring back to the T cells and activate them again. However, what I will touch today will be slightly different than the traditional chemo and radio combination which we have been seeing. And at the same time, we see that how can we actually increase the antigen presentation as well. So let's just look into the cell infiltrate resistant. So as I mentioned just now, we know a lot now about PDL1, and this has been a ligand or domain where we have been focusing quite a bit in the past 10 years. But another interesting pathway is the LAG3, which is also a lymphocyte antigen uh, ligand, and it's really a surface molecule which express on the T cells and other immune cells that has diverse inhibitory biological effects. So we know it is present on the CD4, CD8. It is also present on some of the natural killer cells, and also the memory cell and Treg. So by manipulating this pathway, that means the tumor can actually deactivate the natural killer cells. It can actually use the Treg cells to actually inhibit the T cells. So it's really an interesting pathway to explore. So what we think is by manipulating it with retalimab, which is a LAG3 monoclonal antibody, we can actually inhibit this ligand. And when we do, and plus a PDL1 at the same time, we can ensure that the T cells remain active, and it will actually kill the tumor cells. So now let's just go into one study. This combination, Nivo and retalimab, has already been approved in US for melanoma, for advanced melanoma. But the study I want to show today is really the advancement it has made in neoadjuvant. And neoadjuvant really is a space where we want to focus a lot because we really encourage early detection of cancer. And in neoadjuvant space, really the treatment is given for a definitive time with the hope that the recurrence-free survival is much longer. So it actually had a modest effect in melanoma. It really increased survival by 10%. So let's see how is it doing in neoadjuvant. So in this neoadjuvant setting, we really look into MMR deficiency, non-metastatic colon cancer. Uh, the recurrence, what we know traditionally with standard care of chemo, is still relatively significant. And in niche 2, the combination of nivolumab with CTLA-4 shows that we can actually use immunotherapy in this early setting to have a pathological complete response by 67% and a major political pathological response by 95%. So it's really worth to explore what if we put a PDL1 and an anti-LAG3, which we know from melanoma study has a favorable toxicity. Can we actually achieve a better results? So this was the study design. We had patients previously untreated, resectable, MMR deficient, colorectal adenocarcinoma, no distant mets or locally advanced disease. That means the stage of the disease should be T3 and below. So we actually gave them nivolumab 480 mg plus letalimab 480 mg 8 weekly and 4 weekly prior to surgery, followed by surgery and follow-up. So it's a small study because this is early phase, but this is just to see whether there's any early signal to do a registration trial. So there was only 19 patients. Median range was 56. Half of them were female, and you see majority of them presented at T3 disease. Lynch syndrome was detected in 26% of them. When we look at the toxicity, generally favorable. Most of them had only grade 1 or grade 2, with one case of hyperterrorism with grade 3 hyperterrorism. And we know even from the early studies for any immunotherapy that when combining immunotherapy either alone or even with chemotherapy or other IOs, we know that immune-related side effects is generally something which is worrisome, and we always should keep an eye for it. So result in this early phase study was quite significant and promising. We saw 100% pathological response. Major response was 89 and complete response was 79. And if you remember from the earlier slide, the complete response in the other combination was about 60%. So we managed to increase the response by over 10%. So this really shows us that the LAG3 not only for metastatic disease, but it probably should be pushed and studied more in the early phase studies as well. So I really believe that after PDL1, the only ligand which has actually made some significant impact in clinical studies is right now only LAG3. Although traditionally we have been focusing on OX40, TIM3, and many other co-stimulatory or co-inhibitory receptors on the T cells. But so far in 10 years, this is the only other ligand after CTLA4 and PDL1 which have shown some, road into clinics. So let's focus at I have another 5 minutes, and let's just focus a bit more about interferon signaling related resistance. There are really two places where I think we are really making a significant breakthrough, and perhaps we will see more and more studies focusing on this, and that is the oncolytic virus and vaccines. So this is a 5 years follow-up of TVAC. The full name, I can never get it right, so I will refrain from pronouncing that. So it's in short, it's called TVAC. It's a modified herpes virus which has been used in melanoma and in head and neck studies. So just to share what is the 5 years follow-up for this study. So we have previously in ESMO was reported the 2 years recurrent survival of TVAC alone, TVAC plus surgery, which was 29%, or surgery alone, which was 16.5%. And today, what we are trying to do is really look at the 5 years analysis. So, TVAC, like I mentioned, is a modified herpes oncolytic virus, which is usually injected directly into the lesion. And what it does is really to cause the tumor cells lysis. And again, we hope that that kind of lysis will relieve the DAMPs, which will be picked up by the dendritic cells to go and then activate the T cells and trigger an immune response. And was the study design: about 150 patients given 6 doses of TVAC after followed by surgical resection, and after that no other intervention. And that's why focusing on early detection and early treatment is important, because these patients really did not have any treatment after the surgical resections. So I will just go through the overall demographics. Basically, most of these patients, after the early treatment, some of them did receive some immunotherapy in the later lines, or those who actually progressed did receive some treatment in metastatic disease. This is how the curve looks like after 5 years. A very typical tail end, which we usually see with a lot of immunotherapy. We really have managed to reduce the risk of recurrence by 50%. So you can see the hazard ratio of 0.54 over here. And with this, in the past 3 years, we have seen many studies focusing on TVAC, and you can see various combination, whether it is in cutaneous or non-cutaneous setting. And we have seen quite a favorable response rate as well. So this was the first study to actually combine TVAC with CTLA-4 for unresectable melanoma, and we actually managed to almost double the response rate. And when we look at the master key as well, and then the other one was for non-cutaneous melanoma, and we have made quite a lot of advances also in head and neck cancer when we talk about oncolytic virus. So definitely a pathway which I think there will be more and more studies coming in. Second thing, just to quickly touch on vaccines. One of the study is actually HERVAX, which was reported about a year and a half ago. And this is really to B cell immunotherapy vaccine against HER2 positive disease. So this was the study design, and the vaccine are really given with an increasing interval of 7 days. So total patients only receive 5 vaccines. And just quickly to jump to the results, in this small sample, it actually have shown to really increase the median overall survival with a very decent hazard ratio. But again, this is an early phase study. We need to look at a double blind study to really see how successful it was really, but really shows a very good and promising uh, headway into vaccines. And if you really see, it really shows a very nice plot which shows us there is a long-term IgG antibodies against HER2, which we really think, really hope can actually last for a much longer time to ensure that there is no resistance, or the disease occurrence can be delayed even further. So just one more slide to share on a different approach. This is really DNA medicine. It's a very young and upcoming company. They have few molecules and it's really focusing on DNA composed plasmids. It really focus on three tumor-associated antigens, telsomere, which is very important for GBM, glioblastoma, and also prostate-specific membrane antigen for prostate cancer. And in a very early phase, it actually has shown some significant median overall survival, but we really need to wait for much more robust data. But again, a vaccine making a breakthrough in clinical settings. This is my last slide. Basically, to summarize, we know there are a lot of different resistant mechanism, but I think practically and from a clinical viewpoint, perhaps when we look at it, it really can be divided into three, which is the inflamed tumor, where we know the tumor is really infiltrated by various T cells, lymphocytes, but there still can be a variety reason why there is resistant. Secondly is immune excluded, where we really see there is immune cells, but then it's really on the peripheries and did not really manage to penetrate the tumor. And thirdly is really the immune desert, where we really need a lot of priming to really involve the tumor cells. And really, this is how we need to focus on our research. We really need to focus on when we are doing a combination of treatment to ensure that we can really have a combination which can make a significant breakthrough in clinical setting. So with that, I'm already 2 minutes up, so I will stop over here and probably take some questions.
Thank you so much, Dr. Sethi. I think that's really a very wonderful, very insightful, updates on the immunotherapy. Especially you give us, some case studies that's ongoing. In fact, you have more minutes, another 5 minutes. You could even further on the talk. But let me check if there's any incoming questions for you in the chat box. So there's none. Um, so you still, I mean, those are online. You can still write the question. So Raj, maybe I would like to ask you, it's quite evidence you talk about how that, especially the niche three clinical trials, right? The phase 2 trials on a neoadjuvant. It seems combinations gives the better therapeutics. But my question would be, how personalized it has to be, it should be in the future. Can we really go that personalized or that precise? What would be the work required? Because I almost see multiple combination based on, of course, based on the favorable toxicity, the ligand that shows the favorable toxicity. But I'm just wondering how personalized it should and it will get.
Mm.
Maybe my next question would be whether the mutation drivers, because that's going to be very different landscape according to the different population worldwide. Because what probably the mutational driver you see in a Malaysian patient population might be very different than elsewhere. How that would be even going to be dictate the personalized medicine?
Yeah. So that's really a great question, Selvee. And really, I did not touch on biomarkers in this presentation at all, because that's a whole, planet to conquer by itself. And really, I misread the time. I thought it was only 20 minutes, but there was one last slide. Basically, this was the two last slide which I wanted to leave everyone with. And why is that? It's really because when you talk about personalized medicine, we really need to understand what exactly is happening in tumor, right? And unfortunately, until today, there is no study which is really focusing on only including patients who have inflamed tumor, or only including patients who have immune desert tumors, right? And if you really want to personalize, I think we really need to look, first of all, what exactly is happening in the tumor, and then really understand that what is causing the resistance. Of course, there are a lot limiting factors. Of course, we can't really use an NGS to really diagnose what is happening in the immune system or the tumor microenvironment, right? But I think a lot of the biomarkers are still not validated. Some breakthrough has been happening with fibroblasts. We know that even we have a very specific or precise radioligand treatments, which is lutetium FAPI, which really works very well in cancers where fibroblast activities are very strong. I think there's a lot of work. I think the initial two biomarkers which we know, which is tumor mutational burden and PDL1, although it has shown to improve or enrich the population, it's still not a final solution because still about 40 to 50% of the patients do not have any response. So I think it's a very pertinent question. It's something we really need to focus on, but at this point we do not have a solution. But I think this slides is something we should remember, and if there's any effort in research, this is what we need to remember at the back of our mind, that how do we categorize the patient, really describe the tumor in terms of what is exactly happening, to make sure that we can minimalize treatment, maybe just use one treatment instead of two or three, and be more precise.
Yeah, Raj, you're really right by, bringing the discussion towards what's ultimately the right for the patients. But eventually, we also need to think about the cost effects, whereby, the more it's not going to be the good either. In my understanding, maybe I'm saying this is really interesting, but how much stratifying patients with the biopsies, looking into the inflammations, immune profile, the stromal, that based biomarker would be a superior approach compared to a mutational rival, the conventional way where we're going to do the, classical biomarkers plus maybe a new biomarkers to really tell us, is this tumor going to respond to the combination therapy, or which therapy combination is going to work. I don't know. I'm still maybe thinking from the conventional way, the rival mutations might have a stronger indications how the therapeutics outcome going to be than on these, because this is still a lot of work need to be done, but I'm still on that path. What do you think about it?
Yeah, so you are right. I think, like I mentioned, when we talk about CXL one mutation and IDO mutation, it does alter interferon gamma expressions, but again that's one of the branch. And when we talk about tumor microenvironment, and we really talk about how the fibroblasts get activated, how the macrophages get recruited, I think those are the things which may be happening very locally. Again, some, of course, the mutations which you don't know, right? There might be something which can be detectable in the future. I think really liquid biopsy is making so much advances. We can now look for minimal residual disease in so many various tumor type. I hope we make more advances, whether is by simple, under the microscope kind of diagnose, or whether it's looking at circulating DNAs. I think either way, what is important is we need to understand the complexity of what is exactly happening, because maybe one pathway and one thing may not be the answer there. When we talk about immune system, it looks like the cancer is really manipulating various pathway to escape the immune system.
Yeah, that's very useful, Raj. I think, maybe for those who are from the faculty and University Malaya, those who are actually going to listen to this later
Mhm.
as well, you highlighted the importance of biomarkers, but these biomarkers are very specific to probably resistant, probably the relapse indications, the prognosis, as well as what you highlighted just now, the work The ongoing work that can be really flourished further is the liquid biopsy circulatory, circulatory markers that will then give us a closer outlook. How personalized and precise the therapy can be. A lot of work need to be done, but I'm glad that you bring us these concepts and highlighted where the research should really go on. So with the interest of the time, but thank you so much, Raj, from on behalf of the Breakfast at UMHealth team. I would like to thank you for your time, and we catch up soon.
Yeah, sure, certainly.
Right. Thanks, Raj. And the next episode, I think I'm gonna hand over to Dr. Claire. Thank you so much, everyone.